All right, I want to welcome everybody back. We're very excited to have our keynote address. And first, I'm going to just quickly introduce our next moderator, who is Dr. Rashman Savani. Dr. Savani was born in Uganda, and he obtained his medical degree from the University of Sheffield in the UK. He completed pediatric residency at Duke University Medical Center and neonatology fellowship at Cincinnati Children's Medical Center. He then moved to the University of Manitoba and Winnipeg's Children's Hospital, where he was an assistant professor of pediatrics in the section of neonatology. He was recruited to the University of Pennsylvania and Children's Hospital of Philadelphia, and then moved from CHOP Penn to UT Southwestern Medical School in 2006 and became a professor of pediatrics there. He was awarded the William Buchanan Chair in Pediatrics in 2006 and is currently the division chief of neonatal perinatal medicine in the Department of Pediatrics. Dr. Savani was the chair of the perinatal committee of the North Central Texas RAC, was instrumental in the merger of the RAC PCR and TCHMB sections, and he's currently the vice chair of the executive committee of TCHMB. Rashman, I'm going to turn it over to you.
Well, thank you so much, Carrie. This is a fantastic start to the two-day summit, and I'm absolutely thrilled to be able to introduce Dr. Deborah Bingham. Deborah Bingham is the founder and executive director of the Institute of Perinatal Quality Improvement, PQI, and an associate professor of healthcare quality and safety at the University of Maryland School of Nursing. In these roles, Dr. Bingham is working to expand the utilization of implementation science and improvement science theories, frameworks, methods, and tools in an effort to eliminate preventable perinatal morbidity and mortality and eliminate perinatal racial disparities. She and her husband are proud parents of 4 children, 13 grandchildren, and 4 great-grandchildren. Deborah, you don't look old enough to have great-grandchildren, but so it's a real pleasure to have you, Dr. Bingham.
Thank you so much. It's great to be with you all today. And I'll be talking about how QI saves lives. You've all just had a lot of data thrown at you this morning, and then we're going to be talking a bit on how we can make a difference, what we can do to change outcomes. And QI does save lives. Now, I've asked clinicians previously to raise their hands. You could raise your virtual hand if you would like to. If you're like super gung-ho about QI, then raise your hands and let me know. And sometimes when I ask that question, people are not necessarily, they're a little shy about it. I don't see a lot of hands going up. And then I say, well, how many of you want to save people's lives? And then everybody's hands goes up. But QI is how we save lives. So we're going to dig into that a bit today of how you can make a difference. I'm going to go over some of the urgent issues, not belabor the statistics, but just reinforce some of you may not have been able to hear some of the earlier presentations, talk about some QI methods and strategies for addressing these disparities and these poor outcomes, and also looking at patient-centered care and how we can implement practices and help manage. I think that ultimately helps us manage our stress as clinicians. So my story is, and I'm going to be pretty vulnerable in today's presentation. I'm going to talk pretty personally, start more generally just saying why I became a nurse, but I wanted to help people. I like the idea of helping people. I like to fix problems. I like to learn and share, design and implement programs. So why did you become a perinatal professional? So why does this work matter to you? What is it about it that that motivates you and encourages you to work in this area? And when I started the Institute for Perinatal Quality Improvement, it really is my personal mission. And many of you can adopt this same mission, but it's to expand the use of improvement science to eliminate perinatal morbidity and mortality and end perinatal racial and ethnic disparities. And I won't feel like my work is done unless those outcomes change. So first, let's talk about urgent issues facing mothers and babies today. And it's kind of upsetting that we don't have better data to say that we've been able to reduce this 17-year gap between what we do and what we know. But actually, this is still a relevant data statistics. I haven't seen anything that says we've gotten better and have reduced this 17-year gap between knowing and doing. And we do have research to show that although respondents like yourselves want to make a difference, want to implement evidence-based practices, they don't feel like they have the skills. So that's what I work on through the University of Maryland, as well as at the Institute for Perinatal Quality Improvement that I founded. So it's really very urgent in our country. We have Mississippi with 8.4 infant deaths compared to Massachusetts with 4.2 infant deaths for 1,000 live births. And then if we look at Texas, if we look by race, ethnicity nationally, we also see this image, this picture of in these disparities of non-Hispanic Black infants, 10.8 compared to the non-Hispanic white babies, which is 4.6. If we look at Texas overall, we see a wide range of statistics, and you can see different disparities vary depending on where people live. This is due primarily to the lived environment, not necessarily to the individuals themselves. So if we look at leading causes of infant death by race ethnicity, I circled that the non-Hispanic Black babies in your state are disproportionately affected. And the leading cause both in your state and nationally for infant mortalities are congenital malformations, short gestation and low birth weight, maternal complications of pregnancy, sudden infant death syndrome, and unintentional injuries. So the initiatives for supporting maternal health do also improve infant health. But when we move now to maternal mortality and we compare ourselves to the rest of the world, we see that our maternal mortality rates have been increasing at the same time other countries have seen their rates decreasing. And if we compare our infant mortality rates to the rest of the world, we also do not compare very well. So this is nationally very embarrassing for us as such a wealthy country who like to think of ourselves as really very doing a really good job, but other countries have been able to have much better outcomes. The US maternal mortality ratios, this is just another way to look at what I just showed you, comparing us in the US to other countries and their maternal mortality ratios. If we look at pregnancy maternal mortality ratios by race ethnicity, we see a 3 to 4 disparity between Black non-Hispanic women and white women. So this disparity persists as well. We know from case reviews, just like you were just told this morning, that a lot of these deaths are preventable. And a lot of the preventability is really is related to hemorrhagic deaths, severe hypertension, pulmonary embolism are some of the key leading causes of death that are preventable. Now I just lost my arrow that I was clicking on. Let me see. Oh, that did work. So hopefully that works. And this was a chart within from your own state data. That shows preventability, and it was, if you see at the bottom, it says no chance, some chance, or good chance, then you can see infection, hemorrhage, preeclampsia, eclampsia are all some of the leading causes of preventable deaths in your state. And this is important. As a QI person, I look at the data, I look at the problem, and take those data to say, where can I have the biggest impact? And if you take preventability, and so there's leading causes of death by preventability, gets you to where is a great place to begin to focus. Okay. I did lose the arrow, so I guess somebody else is progressing for me. Back to the other slide, the iceberg slide, or maybe that was me. I accidentally clicked it. Okay, there we go. Maternal mortality is just the tip of the iceberg. Next slide. And we see maternal morbidity has also risen nearly 200% in just a very short period of time, most of that being driven by blood transfusions. Now, I'm not saying we don't need more transfusions. In fact, the data I know from my work in California, reading every death that occurred over a 3-year period, was that we weren't getting blood, women were not getting blood soon enough and were dying from not getting it. But the question becomes, why are so many more women needing blood? And so, I mean, we cannot ignore the fact that there's been a rise in C-sections and a rise in inductions of labor. What is the leading cause of hemorrhage? Anybody know? Want to put it in chat? Uterine atony is the leading cause of hemorrhage. We can look at our data and can say that one of the key preventable ways to reduce uterine atony is to eliminate overuse of inductions. Another cause of hemorrhage, or I should say that if you mode of birth leads to, if you have a C-section, you're going to have more blood loss. So there is also some correlation between mode of birth and the amount of hemorrhage. But just to be clear, you know, the main preventable area for reducing severe maternal morbidity related to hemorrhage is to eliminate overuse of inductions. Next slide. So in Texas, you have higher rates of severe maternal morbidity than the national average. And you also have huge disparities, 299.4 for Black non-Hispanic women, and 182, about 150 for white non-Hispanic. So you have opportunities there as well. Next slide. These data are not just affecting women, they affect the whole healthcare team, doctors, nurses, midwives, causes secondary trauma. Many of you may already have experienced that. I know that when I was a director of nursing in New York City and we had a maternal death, it was devastating to the team. Sometimes people leave the profession because of these events. And so it's very hard we want to eliminate them. We need to talk about them. We need to look at our data, but it's also can be very, very hard to hear these data. And the stress can be extremely severe. So we do also need to take very good care of ourselves. Next slide. So, but just to be also very clear, how one fares in the United States is characterized by a racial division at a person's birth. And that is something we all can change. Next slide. And there's several myths that go into why this is the case. We often have the myth, and you'll hear it throughout your labor rooms. You may have heard it today. Some of you may have actually said it today, but it's this myth around that people assume that they're sicker, older, and fatter if they're Black, Black Hispanic, Black non-Hispanic, that somehow it has to do with the woman, and that's a myth. Next slide. There's a myth that these are inherent racial traits and bad genes, but it's a myth. There is not a Black gene and there is not a white gene. So it's no scientific basis for race. Race is made up. it has the definition of who belongs in which races has changed over time. So it's just, this is another myth. Next slide. So it brings us to race isn't the risk factor, because race is made up. We assign people arbitrarily to race. Then really the risk factor is racism, or how people are treated and how we treat people when they come into care. And this is, you see on this slide, links to the American Medical Association's work and policies around reducing, facing these realities and trying to get rid of these myths in medical education. And nursing education also is working on getting rid of a lot of these myths. Next slide. So it becomes, when we realize that there's race is not biology, race is not genetics, but race has disproportionately caused harm. Color of people's skin, people make assumptions, negative assumptions, and also are more disrespectful or treat people differently. Then we realize that it's a human rights issue and that it's completely unacceptable that Black women are 3 to 4 times more likely to die when giving birth than white women. And also the infants are more likely to suffer harm and infant mortality. Next slide. So women and newborns die or suffer these preventable injuries because of overuse of medical interventions, underuse of effective, aggressive life treatments. Next slide. So, but I know deep in my heart, I believe very clearly that all of you want to do good. You don't become a nurse, a doctor, or a perinatal health professional wanting to harm anyone. But we have gotten used to doing some things that are very harmful. But when I was quoted in the several years ago in the USA Today article, I really strongly believe this, that nurses and doctors believe they provide good care and don't want to harm patients. But it's very hard to accept that this use of this oxytocin today, willy-nilly for no medical reason, can cause harm. It's very hard to change those behaviors. It's very hard to accept that this overuse of C-sections is leading to such poor outcomes. And it's hard to accept that what I've been doing for years may not have been the best way to do it. It's hard to accept that separating moms and babies at birth, not giving them skin to skin, all of these things that have been going on for a number of years. Let me give another one. Estimating blood loss. It's hard to believe that that isn't going to cause problems, but moving from estimating to quantifying will make a big difference. So anyway, take time. Try not to react negatively to what I'm saying, but try to just let that soak in and let you open your eyes to what is it that I personally need to change in order to improve outcomes for moms and babies. What is it that I need to do different? Because if each one of us reflect on that and we then make some changes, because believe me, if we keep doing what we're doing, we're going to keep getting the same outcomes. So we have to make changes. And what is it that we personally need to do differently? Next slide. So my son died in the fall. I told you I was going to be very vulnerable, and if I start to cry, I hope you just bear with me. I'll get it together to finish the talk, I promise. But I wanted to just point this out because I think his quote is very, very much in line with what I'm saying. And he was a professor at Boston University, devoted his life to improving outcomes in communities. And he has a book that he wrote that's in the process of, we're editing it, and it will be published shortly. Oh, and thank you for the heart messages. That's very sweet. So I'm going to read this quote from him. I came to better understand that racism is more than bad people intentionally harming someone else they view as inferior. It can take that form, but it is also people, sometimes including me, he's talking about himself. And I want you all to realize that it's also, I'm saying it also is me. I'm not saying this is, I've got it all figured out. I've got my own implicit biases. I don't mean to cause harm, but I will say and do things that are harmful to others. And I don't, we don't want to believe that we're racist. So but it is also people, sometimes including me, who believe they are not racist, but who are unable to acknowledge or unwilling to change the systems that structurally benefit them while disadvantaging entire groups. The more time I spent in Mississippi, the more I was able to see the same inequities and racism in my own community. So I want you to take some time to see, open your eyes, open your heart to see the ways in which we are taking care of people differently. Thank you for your hearts. It's so sweet. Next slide. So now let's talk about what we can do differently. Next slide. I'm going to go into some theories, and just give you what is the definition of QI. It's systematic, data guided, and your state is amazing. It's got all this data for you to work from. That can be a bit overwhelming, but it's still very important. And you use that data to bring about immediate positive changes in the delivery of healthcare in particular settings. So each of you need to design and customize your work to your settings. Next slide. QI is the responsibility of all of us. It's the responsibility even of patients. It's different than research. Research is where we're trying to learn something new. QI is taking what we already know and implementing it. Next slide. So it's not discretionary. It's not nice to do. And this is from the ethics think tank on the big Hastings Center, like our premier ethics think tank. This is not something that is discretionary. It is something that is our responsibility. Next slide. Location matters, and it shouldn't. This is what we need to change. Location should not matter, but Dr. Howell identified that minorities receive care in different and lower quality hospitals than whites. And I think you could, if you're honest with yourself, you might know of hospitals within your area that are not giving as bad, the outcomes are not as good as other areas, other hospitals. Next slide. She took New York City hospitals and this is one of her studies. She's done many really excellent studies. In this particular study, she looked at low Black serving, medium Black, and high Black serving hospitals and looked at the difference in severe maternal morbidity by whether they were white or Black patients. And you can see that in the high Black serving hospitals, there is very little disparity. Everybody had bad outcomes, like similar bad outcomes. Not everybody, but there were high rates of severe maternal morbidity consistently, regardless of the race. And then in the low Black serving hospitals, that was where the biggest disparities lied. So I love the goal that you're all set for your state, that you'll be tracking your data by race, ethnicity. It's critical that you start to do that and be able to see your disparities within your own facilities. And these should be self-reported, race, ethnicity, and just eventually hopefully we'll be able to see all people the same, and we won't need to use these made up categories for tracking our data. But for now, these disparities can be invisible, and we can think we're doing really well. I had a group tell me the other day, until they looked at their pain data, they had no idea that they were giving less pain medicine to people of color. Others saying, I didn't realize until we looked at our data that we were having security called on people of color more often. So we need our data for now. Next slide. In this study by Dr. Howell, they found that if Black women delivered at the same hospitals as white women, their results suggest that nearly 1,000 Black women would avoid a severe morbid event in just New York City alone. 1,000 women a year. And severe morbidity is somebody almost died. This isn't a UTI. So these can have lifelong consequences, these morbid events. Next slide. And it's gotten a little worse. We've got more miscare, more moral distress, and more burnout. So, but that's when QI can feed your soul. It can help you feel more empowered and more have work that really is very powerful and meaningful to you. Next slide. So I created, you know, when we think about, I'm a professor, so here we go. This is the disclaimer. But I was trying to figure out how do we talk about QI theories and implementation science. Some of you may be academics and may have heard some of these words being batted around. And how does QI fit with human research, human subjects research? So I just made up this table, this figure to help, this flow chart to help kind of show these differences. So number one is identify the problem, assess the situation. That's QI, but it also it can feed research. And so you can see the arrows going into research. If you're going to go on and there is an evidence-based intervention that needs to be implemented, like we know we're overusing C-sections, we're overusing induction of labor, we don't need to do more research on that. Now we move to step number 2 in the yellow, which is the QI implementation. And then we do number 3, which is the evaluation. We use implementation science to inform our designing of an implementation project, and improvement science as well guides us in how the methods and the tools to make our projects more effective. Next slide. So if you, one more time, thank you. If you think about it this way, that implementation science, these are scientists who are studying how to more effectively implement something, and their theories and tools make a big difference in helping us make decisions, and it's the physiology of QI. So it's understanding this research, and I'll give you some key findings from implementation scientists. Next slide. One of them is Rogers. He's studied diffusion of innovation for over 50 years, and he has implementation as its own subcategory, but there's all these steps before you begin to implement. One is you need to make sure people know what needs to be implemented. You need to persuade them that they need to implement. 3, you need to have them decide to implement, and then we get to implementation. So you have to do all those steps with your teams. And then the confirmation is that's just how things are done. Next slide. And so let's talk in number 2. We're going to go through, I'm assuming you know how to review the literature. You already have your data. Now let's move into section number 2. We're going to design and implement our quality improvement initiative. So next slide. Next slide. Yeah, so there are QI process models. These are not theories. These are really more like protocols. These are step-by-step. Here's what you do to move the initiative forward. One of them you've heard of is the model for improvement. The theories would feed in to help you know how to do each of these steps. They are not the same as the model. Another model is, the next slide shows, is what's called MAPIT, or the Mobilize, Assess, Plan, Implement, Track. It's used a lot in public health. Next slide. And if you see these models like PDSA cycles, you're working them to improve. Next slide. And you might have heard of Six Sigma. That's also a process model. It's not a theory. It's not it's not the same as as a theory. It's a process model. It's just a step-by-step approach. And you take map it and apply it to Six Sigma steps, and you can see a lot of times it's semantics. So you can, it doesn't really matter what process model somebody's using. I'm going to go with map it today because I love that map it has mobilize as the first step. And a lot of these process models forget that step, and I think it's a really critical step. And the summit you're doing right now is actually a type of mobilizing of your entire state. The next one, so I'm just going to go through the next set of slides, giving you some examples of how you use a process model in order to ensure that all women have high quality care, because everyone deserves high quality care. And when we seek to improve the care for all people, and in particular focus in on disparities, we are going to benefit everyone. One of the things that when you're thinking about mobilizing is that remembering that conversation is where change begins. And we all have the power to change the conversation. So, so at a minimum, you all can just start your implementation project by mobilizing people, by starting to speak more respectfully of every person who enters your care within your sphere of influence. Not roll your eyes, and I'm talking discourse. If somebody comes in multiple times, that's because they need help, they need support, who knows what's going on at home, not judging. And we all been there, we've all heard it, and we've all maybe participated. It's time to mobilize to be different and to be completely respectful. Next slide. And never, never underestimate the power of a small group of people in order to change your system, in order to change the world, because that is the only thing that has ever been able to change the world. Next slide. So you have your morbidity, mortality reviews, and you need to think of QI opportunities, not try to pat yourselves on the back, not try to blame and shame, but what are our QI opportunities? What can we do better? Next slide. What can I do better? You want to make your assessments. Next slide. And I use this, we created this at PQI, at the Institute for Perinatal Quality Improvement, to show the path of different people, a white person compared to a person of color who enters in trying to reach health and prosperity. It's not that they won't be able to, but it's just a much harder path. And on her backpack, it says 246 years of slavery. And I'm going to be really vulnerable here and tell you, before I made this graphic, designed this graphic and dug into the literature, I hadn't really thought about the fact how many years slavery existed. No wonder we're still struggling with it, right? I mean, that's a lot of years in our history. Yeah. So next slide. This is I use QI tools to help us sort through complex issues like perinatal disparities. And this is an Ishikawa diagram. I have people legitimately saying, but I don't get it. What could I do different? Well, first off, look at your teams. Are your teams reflective of the patients you take care of? You know, are y'all a bunch of white people on your review committees? You know, so who are we listening to? Who are we hearing from? And also recognizing historic trauma and its effect on outcomes. Next slide. Your plan. Then you put together a plan. Next slide. And you want to have SMART goals, SMART, specific, measurable, achievable, relevant, and time-based. A specific goal could be, I'm going to read books on how to be an anti-racist. I'll read 3 this year, or I'll read 1 a month. You could say, I will not participate in any jokes, in quotes, that are disrespectful of another human being. Next slide. So here's some, and you can pull these slides up and read these later, but one of them could be like you're going to track all your morbidity and mortality data by race, ethnicity. Next slide. You want to be very clear. We're not looking for equal treatment. My 10-year-old granddaughter says to me, she has learning needs. And she said, you know, what's fair is that people get what they need, not necessarily get the same thing. So equity is making sure everybody gets what they need. If you look at this image, we created this also at the Institute for Perinatal Quality Improvement, because the other images weren't telling the story well enough. 3 boxes off to the side. There's plenty to go around. They're not being used. There's a lot of resources. People get really like, this is mine. I don't want to give up my box. The people in this image are all the same height. It's the ground under them that is different. By giving the purple person 2 more boxes doesn't give that person more fruit. It just gives them the same access that the tan person already had. So let's not be stingy. Let's not work from a scarcity frame of mind. Our country is very rich. Texas is very wealthy state. We have plenty to go around to make sure people get what they need in order to have the best outcomes. And believe me, we eliminated disparities around immunizations when we started to increase resources to communities of color and communities with greater needs. Next slide. These disparities are not baked in, they can be changed. Implement, next slide. We use the Speak Up acronym and mnemonic, which is to help everybody remember all the things we can do different. We can all set limits, say not on my watch. We will not talk about people around in that way when I'm here. We'll practice and prepare, express concerns, apologize. We're all going to screw up. We're going to say something we didn't mean, or where our implicit biases come flying out. But that doesn't mean we shouldn't try. That doesn't mean we should just say, I'm too scared to say the wrong thing. No, go try, at least do the best we can. Keep improving, uncover and learn, use our data, persuade others. Next slide. We also, I'm really excited to inform you all, some of you may already know about this work, but we at the Institute for Perinatal Quality Improvement with TTAF and primary maternity care received a planning grant to expand the use of intermittent auscultation in the state. And we've been just finishing up the planning grant, and we will be having a webinar outlining what we've learned and also just kind of next steps. So some insights for safe and successful implementation of intermittent auscultation. Next slide. So that gets us to tracking. Next slide. Don't be afraid to look at your data, and don't be afraid, that's how you know you need to improve. Next slide. And then you want to share what you learn. Next slide. And you want sustainability and spread. Next slide. And one finding from the implementation scientists is, guess what? If you're a committed leader, you will overcome barriers. That is one of the keys to success. So if you're wondering why your QI initiative is not successful, look first at yourself. Next slide. And take time to celebrate each little step along the way. Next slide. I went and saw, I had the opportunity several years ago to go to Monet's water lily pond. He painted a lot of water lilies pond just to get the light just right. So don't, you just keep repeating and learning, and that became his masterpiece. Next slide. For me, this is one of my masterpieces, helping bring down maternal mortality in the state of California in such a short period of time. You all can do the same thing. There's nothing magical about what we did. Next slide. Just make time for QI. At the end of the day, that's what really matters. Next slide. Because QI saves lives. So I think we now have time for Q&A.
Oh, thank you so much. That's a really terrific talk. the things that I took away, which were so profound, were other than your amazing son that you created, it's a human rights issue, and that your zip code should not determine your outcome. So I really appreciated your comments. I'm going to get things started off. I was really struck by the incredible lack of return on investment, right? So of all the developed countries and the outcomes that you showed, Italy was at the top with the lowest morbidity, and there we were right at the bottom. And the amount of healthcare expense that goes into those two countries, I believe we are spending double the amount of money from Italy. Is that correct? How would you factor in healthcare expenses with respect to the outcomes that we're getting? Because I think we're getting shorted for our money. You're on mute.
I don't know the exact percentages, the differences between our two, but we are definitely overspend every country I've ever looked at with better, and they have better outcomes. And that's why I brought up the three classic areas for QI work is overuse, underuse, and misuse. So those are the three areas that you look for. Is this a situation of overuse, a situation of misuse, or a situation of underuse? And we have situations, if you look at your maternal mortality data, which I did, there's where it's overuse, other situations where it's underuse. So we have, and you can have the same, flip the same coin. So there's underuse of physiologic birth, vaginal births, and overuse of C-section. So you could work too on those two things. And you think about all how much more it costs to have a C-section than it does to have a vaginal birth. In birth, there is no one who would argue that we are not overusing C-sections. We are definitely overusing C-sections, and that leads to more infant morbidity, long-term morbidity for the mom, short-term morbidity, longer hospitalizations. It just all is expensive. And so that's that's one reason why we're working on intermittent auscultation, because that will help promote physiologic birth. So that's an underutilization piece. So yeah, thank you for that question.
And then the other thing I thought of was, we made considerable headway in limiting birth before 39 weeks gestation. I think that actually was part of the reason some of the preterm birth rate has gone down
Right.
in certain areas. And I was struck by your analysis of decreased inductions, right? Trying to decrease inductions. Is there a way that we could apply the same methodology to limit the number of unnecessary inductions so that we could get better outcomes in terms of hemorrhage, et cetera?
Yes, we could require a medical indication for all inductions with very few exceptions. There are some situations where there could be a process for making those exceptions. And I do know hospital systems that have implemented that approach, and they've had where you cannot schedule an elective induction of labor. There has to be a medical indication, or that case goes through a board review within a QI review within their facility.
Another question that came up was, I want to ask your thoughts on implications of individual state insurance policies and outcomes. Some of the states with less disparities, for instance, have better safety nets.
Yeah, so you definitely want the best insurance policies that you can have to help ensure women have as much access, in particular postpartum. There are now states that have women are able to keep on their Medicaid at least in a year after giving birth, and that's going to make it better for everyone. So absolutely, you want those policies, those types of policies available where women can get access. But even if they have access, we have to make sure that when they get access, that they're being treated with high quality, not just safe care, but high quality care. So it's there's two things that at least two things that need to happen.
Obviously, my previous question has generated some chatter in the chat box. The ARRIVE trial concluded that outcomes might be better with elective induction. What are your thoughts about the impact of that trial on mode of delivery and blood loss?
Honestly, those I would quibble with the way that's worded. Looking through that data, it's very select protocol in a very select population. They had, I think it was 50,000 people declined to participate and 6,000 participants. And their main outcome was decreasing C-sections, but there's been a lot of data to show that increasing, doing elective inductions of labor is not the most effective way to bring down C-section rates. And how many of you have C-section rates of 17% for NTSB? So if you're striving to reduce your C-section rate to the rate that they identified in their study, which was 17%, there are more effective ways to bring down your C-section rates. Then they said there wasn't any additional harm, but they didn't really show a lot of benefit. And there's a lot of, and actually it's a whole different talk, but I will say that Bill Grobman himself said, unless you have really good evidence, you should not interrupt healthy physiologic birth. So we can have a whole nother talk about that, but I think until we know better, we should not give anybody medicines that they don't need and not interrupt a natural process in physiologic process. So yeah, happy to go round and round on that with anybody who would like to. So
sure, I think that would be a great seminar in itself. I'm going to see if there was anything. Okay, I'll sort of take the liberty of the last question if I could. In terms of really tracking data, you know, a lot of the data that we've seen so far today is not patient level. It's sort of high level populations kind of data. Can you talk about the importance of patient level data to analyze, for example, variation by hospital, variation by site? If we're talking about geography, then we ought to measure it by geography.
Yeah, so I will say that I'll give a recent example. So we do our Speak Up initiative, our Speak Up program, and in that we talk to people about tracking their data by race, ethnicity. And one of the presentations we gave, this was a big hospital in Boston that is well known for their research around tracking morbidity data. But the nurses at that conference said, you know what, we don't track by race, ethnicity at our hospital, even though they were tracking and writing papers about how to do this. And so the pandemic hit. We gave that presentation on March 6, 2020, the pandemic hit. And they had committed before leaving that they were going to go back and start tracking by race, ethnicity. So they started to do that by tracking first how many patients with COVID came in by race, ethnicity, and found out and realized that all of the patients who came in to their hospital COVID positive, pregnant, in labor, were people of color. But rather than blaming the women, what they did is they looked deeper and said, where do they live? What's happening in their communities. They coordinated, we're in an emergency situation. They coordinated with the Department of Health and said, this community, the women are coming in COVID positive, and they did it rather than blaming the women, and they used that data to immediately have some public health support for that community. So it's those kinds of ways in which we localize and make our data very personal and say, okay, how can I make a difference in my facility? What is it that we need to work on? What's our priorities for action? So, yeah.
Well, Dr. Bingham, this has been absolutely phenomenal. I love the emails you send regularly. I read them with great fervor, and I wish you well. Thank you so much for a phenomenal talk.